Okay, I'll invite the panelists up, sit down. What's not mentioned in our discussions is FDA's role in comparative effectiveness. And I just wonder if anyone on our panel has a feeling for where FDA is. It's sort of the redheaded stepchild with CER. It didn't get that much money. It does do it for safety issues, but does anybody have a feeling for FDA's role in comparative effectiveness?
No.
I do not, yeah. Dig Mike.
So I'm by no means an expert on the FDA, but you know, the FDA has had a long interest in observational data of the kind that you mentioned, and I think that I think it's important for the different organizations that are kind of stakeholders in this, which would include the FDA, you know, the whole medical informatics community and the large databases that are being developed by health systems to try to work collaboratively towards getting good data systems. Because I do agree with you. I mean, I think we need to learn how to use observational data better, and that you know, we're not going to solve these problems through clinical trials exclusively, and so I think the FDA is a stakeholder, provides some expertise on this, but they, I mean, what I've heard from them is that they need partners to do this work. You know, they don't have the resources to do it, but I think, but they do bring something to the table in terms of skills and some data systems that have been developed through their programs.
Right. You know, this point about finding ways to, I actually have a lavalier, finding ways to make the research more viable, faster, less expensive, less time consuming are interesting. And I just came from meetings this afternoon at the foundation where we were sort of looking at, I'm in another group called the Pioneer Portfolio, and we sort of look at breakthrough kind of leapfrogging kinds of ideas. And there were a number of proposals about, well, what about accelerating off-label use of medications used in pediatric populations? Accelerating the research to try to understand that, and using things like mobile health platforms and things like that. So the question about FDA and the role and their supervision, how they might sort of view that kind of that research innovation certainly came up today. We also, incidentally, were talking about other kind of crazy ideas about like using Twitter Stream to as a way to sort of advance and accelerate the research for comparative effectiveness, things like that. So lots of people thinking about how to make this faster. We don't have the answers yet, I don't think.
All right, we've got a lot of questions, so I'm going to try to get to as many as we can. What is being done to publish information for patient understandable results so they can make informed decisions beyond cost?
I'll just make a comment on health literacy. You know, health literacy is a huge challenge, and I think most clinicians are not well versed in that barrier. So I think, in addition to understanding the outcomes that are important to patients, presenting the information in a way that they can actually make an informed decision is an area that actually needs to be studied, because I think if you look at hospitalizations, most patients coming out of the hospital can't accurately recite what their discharge instructions are within 48 hours.
Okay, is IBC predicting? Go ahead.
Just a very brief. So I would actually sort of compliment the Agency for Healthcare Research and Quality. They've put quite a bit of effort into developing sort of a consumer information stream that's really high quality, and that that is a resource that that I think has continued to sort of expand and is as useful. And so that's the effective healthcare program that you had mentioned earlier, Jim.
That's right.
I really agree with that. ARC has done a terrific job and a lot of work and a lot of research on this sort of notion about we've been talking today about developing the information, the outcomes information that matters for people, and as well as the price and cost information, and then marrying those into that sort of value decision that we all have to make. And then I also threw up the orbit slide, which is a way that we're all accustomed to sort of looking at airline prices and sort of making decisions. But we need a lot of understanding about how to sort of present that to various stakeholders. Consumers and patients are one that need to have the presentation. It's not just getting the information, but the right kind of cost information and quality and outcomes information, and then the presentation so that it's usable matters too. And ARC has done a terrific job in helping us understand that usable interface. We have a lot of work.
Yeah, ARC does have great publications. They do make consumer reports type for diabetes drugs, for example. If you go out and look at it, they have the cost and they have the effectiveness, and I remember working with them a lot on that, on the education of that. In fact, it first began at OSU, where the legislation for the ACA, I think, had in it that the language for the patient, the reports, ARC had to do 2 reports, one for patients, one for doctors, and it had to be in their language so they would understand it, and they had to be short, not more than 4 pages for patients, not more than 15, 16 pages for physicians. And they did it. They developed a group at OSU that was doing it. Now Vanderbilt has that, but they had to reinvent the whole way of talking to patients and get it into their language. And they've done a lot of that at ARC. Is IBC predicting that most companies will cease providing health insurance and just have employers go to the new health insurance exchanges for insurance? If so, how long will this transition take?
So my crystal ball is not better than anybody else's. I think we're going to see a big shift towards the individual market, and I think it'll vary by employer. I think our view is that there'll probably be 3 predominant markets at some point in the next 10 years. You'll have large employers, so locally Comcast. Comcast may not want to get out of the business of deciding what kind of benefits they want to offer to their employees, and they're large enough to have scale to do that. I think small employers will probably get out of the business, and it'll vary by what type of an employer you are. If you're an employer, for example, if you're a retail employer that has a lot of employees that are on the lower end of the wage scale, then it's actually easier to get out, pay the penalty, and let them get the subsidies on the exchange. This is not so much an area where IBC is involved, but if you actually look at what's already happening pre-exchanges, and we were having this conversation beforehand, many employers are redefining what it takes to be a part-time worker, and guess what? It's 28 hours now, because the law says the threshold for health benefits is 30. And so I think we've worked with some consulting firms that have surveyed CEOs of large companies, and universally what we're hearing from our advisors is there's not a CEO of an employer that wouldn't get out of the business of providing health benefits if they could. That this is the last thing they want to do. So I think that I will say what I said in my talk, which is we think health benefits are going to go the way of pensions. It's not going to go to 0, but you're going to see that decision. You're going to see employers continue to provide a financial contribution, but the decision to purchase insurance is going to become an individual decision, not the HR department of the employer.
Please address transparency in CER research. For example, what is the percentage of study results that are buried when results do not work out in the sponsor's favor?
That's probably on me. And I'm okay with that. We actually have a transparency policy within AstraZeneca, and I don't know that my peers are all, am I coming across clear? Yes? So I don't know that all my peers are the same, but I can tell you that most manufacturers are in the thought process now of, if I do the study, I should talk about the study and tell people about it. So we have actually a website that actually we throw up every single project on. Everything that we study goes up on the website. It's public. In addition, we go out onto the clinicaltrials.gov site, and everything we do goes up on that site. And if we don't do it, it's a compliance violation. So if you have a researcher within AZ that doesn't do that, then they're gone. It's just simple. Like we just made it a standard within the company that you will publish everything you do, period. And I think that becomes the new level of transparency required in the US and globally. And if we don't do that, as an industry, shame on us.
No, exactly. It's the beginning of that. You know, for years it wasn't that way, but it's coming. Isn't it likely that computers will eventually make clinical decisions for doctors based on CER and cost, efficacy, safety ratios? My feeling is with HIT is very integrated with CER and standards for everything. I have a slide with a triangle like that. But they are, HIT I've spent a lot of time in, as well as CER, because I see that when you talked about the databases as being the future. And are we going to arrive at a time like the astronauts, when they go to the moon, the computer tells them what button to push when, you know? And so is that going to happen with physicians?
So I'll take a stab at that. I think it's a long ways off. The model of medical decision making is that it's collaborative process between patients and providers. It is driven by patient preferences, and so that is an interactive process. And I don't think it's accurate to say that what comparative effectiveness research gives you is the right answer. What comparative effectiveness gives you is information to use in that collaborative process of decision making. And so in that sense, I don't really see this kind of evidence somehow flowing through to a very algorithmic approach, which would be the idea that the computer tells you what to do.
Yeah, I would agree. From my health plan and PBM days, it's about the body of evidence. It's not about one study. And you have to understand the body of evidence to make the right healthcare decision, whether you're at the point of care or you're at the traditional payer side or you're at the IDN, ACO side. You're the decision maker based upon the body of evidence, not about one study. Secondly, I think the systems in today's day and age are getting more sophisticated, but not there yet. They're better than they used to be, but they're not there yet. And it depends on which system you're looking at. And I'm not criticizing any system. I'm just saying if you look at Epic versus GE versus other Cerner and other types of systems that are out there that are point of care, they all deliver a different system to the provider and a different experience to the provider. And then the provider acts differently in their practice because of that system being available to them. And it's just amazing when you get out there and start looking at these systems. They are so different. They're so disparate. And the experience the provider has with that system and then what the patient experiences as a result of that varies dramatically all over the country.
Embedded in that great question is this sort of anxiety about, well, where is this comparative effectiveness going? Is it sort of, is it expanding choice and allowing us to leverage choice to get at value, or is it limiting choice and pushing us toward a rationing by algorithm here or fiat or something like that? So, I mean, our hope is that it's more information for us to make better decisions, and that is our sort of cultural approach. The other point is that we have so many technical problems to get this information, so we're so, insanely far away from that day that, like you said, it's pretty interesting.
I would just say that I don't think it's going to be algorithmic, but I do think that computer-based support systems will need to evolve to support decision-making in a way that they don't do today. One is bringing information into the room with the patient and the physician that's not there today. So I'll just use an example that we're not able to capitalize right now. When patients with hypertension walk into their physician's office and their blood pressure is not controlled, the information, the physician says, "Are you taking your drugs?" The patient says, "Yes." The physician writes another prescription to bring the blood pressure under control. The reality is compliance with chronic medications, if you actually look at what gets dispensed from the pharmacy, on average for chronic diseases between 30 and 40%. If the physician had that information about what was actually dispensed and picked up from the pharmacy as an independent validator, they don't need to rely on the qualitative response from the patient of yes, because you don't know whether yes is once every 3 days, once every other day, whatever. And those are the types of information for just readmissions, at least in the Philadelphia region, 65% of the readmissions that happen to patients are patients going to a different hospital than they were originally admitted to. What information does that hospital have about what happened before? So if you think about those things and bring that information to bear in a decision making, there's huge opportunities to improve decision making.
But again, on this technical point, just the hypertension decision is an interesting one. So there's this famous All-Hat study, and it's sort of the best one, an example of the randomized controlled trial, the best of the best of that kind of effectiveness research, and it sort of astoundingly showed that the old line cheap diuretics were the medicine of choice to treat hypertension. That's your first medicine that you go to. But it also took, what, 40,000 patients, $120 million, 8 years to give us that one bit of information. Then you got to have the next step of information about, well then what if I break through that hydrochlorothiazide diuretic? Do I add an ACE inhibitor or a beta blocker, and then what? And then what? So we can't do that
Or
for
an
every
ARB.
one of those decisions.
An ARB.
Right, or an ARB, right, exactly, right. Right.
Just an idea.
Just saying, right.
Just an idea.
Anybody else? All right. What are meaningful lessons we can gather from organizations like NICE, that's in England, to inform comparative effectiveness research and patient outcomes in the U.S.?
Well, Steve might want to comment on this, but I mean, I think the work that NICE does is to do really sort of formal analysis of evidence reviews of alternatives for particular clinical problems, which I think is a lot like formulary bodies and bodies in the United States that make coverage decisions. And do you think that process is getting better or getting worse?
The coverage decision process?
I mean, how well is that process working?
I think it's getting, well, it's imperfect, but I think it's getting better. I think, again, one person's perspective, I think the transparency of what is covered, because basically now all the coverage decisions are online for everybody, right? Medicare, private payers, et cetera. The criteria are out there. I think it's created pressure on industry, whether it be devices, pharma, et cetera, to produce better information about what's working, why it's working. I think there's the art to applying these things as well as the science, and I think that the challenge that we have is the cost to get a labeled indication, for example, for drugs is such that we're not always doing that, and so the data that is out there on off-label indications, which may be poor, doesn't necessarily mean that the drug doesn't work. So I think it's getting better. I think it's created some pressure. I'll just sort of two examples where it talks about how far we have not come. So I always tell physicians the insurance industry didn't invent prior authorization. And when they look at me with a blank stare, I would say, if you're in a hospital and you're on the medical staff and you want to write for an antibiotic that's on the restricted formulary list for infection control, what do you have to do? And they said, well, I got to call the infectious disease consultant. I said, well, what do you call that process? And they're like, what do you mean? I said, well, I call it a prior authorization. And they go, well, okay, fine. And then I said, well, why do you have to do that? Because if staff education thing worked, why do the hospitals have to put that barrier in place to get you to call the infectious disease consultant to write for vancomycin? It's because if it's easy to do, people will do it, and you have to put some step in place. What happens in that process is that the criteria for ordering become known and disseminated. So here, just an example, when we put in prior authorization for high-cost imaging, MRI and CTs, I actually had a discussion with Pennsylvania Medical Society where they said, well, you know, we spent more time looking at what the indications were for an MRI after you put the criteria out there. And so I would say that the coverage issues create a need to learn, but it's pretty rudimentary still. It gets back to sort of how do you disseminate and get people to look at information and indications. And I would say that's a part, you know, we talk about the systems part of comparative effectiveness. I think the head-to-head trials are great, but you know, as I said, we still don't know how to get clinicians to follow you know, indications that are well known and established. So it's not sort of figuring out what we need to do. It's how do you actually get it into practice? And that's basically what Atul Gawande, that's your quote, is that if we can figure out how to get what we know into practice, we'll probably do more good than figuring out sort of the next piece of evidence in some case.
So if I could just add, I'm sorry. So add on to one just comment to that. And, you know, from you look at NICE from a health technology assessment perspective, right? That's what they do, the health technology assessment critical appraisal. Australia does the same thing. In the US, we have hundreds of PBMs, health plans, employers, others that do critical appraisal and health technology assessment in their own way. So there's no standard here in the US. In the NICE environment, in Australia, in Germany, we have one standard by which we actually, from a drug company perspective, know how to comply. We know what to perform, what to produce, right? In the US, it's getting there, right? It's just not there yet. You have one standard for RCTs, which is, I think, Delphini is becoming the standard for randomized clinical trial critical appraisal. And you have AMCP, ISPOR, and NPC working together on a collaboration to do critical appraisal best approaches for observational type, non-randomized trials type studies. So what's the standard by which you evaluate the rigor of a non-randomized trial? And then how do you synthesize that evidence into a way that you can look at the body of evidence and incorporate that with randomized trial data to say, I made the best healthcare decision based on the evidence I have. So that's all going on right now, but it's really in its infancy. Just got rolled out in April in San Diego. So very much infancy, but closer to NICE than ever before, but not quite there yet. In a nice way.
Do you feel that when patients know more about actual cost of health care and have to pay more of it, that they may begin to change simple behaviors that can change public health outcomes? That is, eat better, exercise more, things like that. Do you think we'll ever hit that day? And that's our last question. Although I've got others, but it's been difficult because as a pharmacist I can usually read prescriptions, but some of the writing is not really clear.
I can take a jump at it, and I'm sure everybody else will have a thought. So on one of the slides, it was the slide I showed, the sort of the distinction between public care spending and private. There was a bar that had the out-of-pocket consumer expense, and it's a pretty big bar. And so that impact on the consumer hits her wallet, and that is a leverage point, particularly if we're behaving sort of in a sort of typically, classically rational economic player. And so you'd like to give that consumer who's having information, who's having an impact on her wallet, you'd like to have her, give her information to make point of care decisions about where she's making a prescription choice or some other kind of purchasing, out-of-pocket purchasing choice. You'd like to have information to help rationalize that. Having said that, the last part of that question was about exercise and all these other behavior changes, and we really need things like behavioral economics to help us overlay how to get people, how to motivate people to actually do these other kinds of things, because the incentives, even the rational financial incentives, that it's hitting your pocket, and if you had the information, you'd be really rational and do this, and you'd make the other calculations to do all these other well-being and fitness and health things. That's probably not going to happen, but we do need people to do that. We just have to get much, much better at figuring out how to motivate people beyond incentives, how to motivate people to do those kinds of things.
It's the same issue with guns with regard to mental health and, you know, addressing the health issues that are involved. Please join me in thanking our panel. You don't realize what you've got tonight was really informative.